So two fantastic talks, both somewhat related because I think especially in the COVID era, we'll definitely come back to you. Santiago, it was a wonderful, wonderful talk. But Tim, let's go to your talk and just talk a little bit about STEMI management. And Naveen asks a very important question. His first question is there any difference in the clinical outcomes based on how that left main was treated? Single stent, bifurcation, stent strategy, especially in the setting of STEMI. This is a really important question. What do you have data on that? Is the single stent strategy the way to go, et cetera?
So terrific question, and we don't know the answer. I think one of the important points about this, and you saw this talk, is really the paucity of data. And so really almost nothing published for the last 7 years. And so what we're in the process of now of actually putting together 5 large regional STEMI systems where we look at all and have all the angiograms to look at. So we're actually in the process of doing that. But also tell you that I would say this to the community, people watching right now, there's been a hesitancy to actually address it from a interventional standpoint. And I think the fact that we're doing left mains electively now, and most interventional cardiologists are comfortable with that, or should be, now should increase your comfort with dealing with it acutely. And so clearly, the percentage of people getting PCI versus surgery has climbed. And I think, especially for patients who have ongoing ischemia or hemodynamically unstable, you need to deal with it. And that's true for not only left main from atherosclerosis, but left main from spontaneous dissection. So we just published a paper in JACC last year of spontaneous coronary dissections in STEMI. Very different than stable or non-stable patients. And you can actually deal with it very effectively with PCI if you're careful. And in particular, 25% of those SCAD patients had a cardiogenic shock and a left main. So it's a common issue with SCAD, and you need to know how to deal with it. You need to be able to do PCI and close off the entry site. And in regards to the single or bifurcation, what I think you need to do is, number one, you need to stabilize the patient, which needs you to get reperfusion. Once you get reperfusion and the patient's stable, then I think you should get best result. So I think, if you saw, the other issue about left main culprits is there's significant heterogeneity. And I think for the patients who's stable, I would do, bifurcation, stenting, take your time to get an outstanding result. But the key first thing is stabilize the patient.
Yeah, so it's a really good point. I think there is a place where I think unloading makes a huge, huge difference. And I wonder if, and as well as very much important imaging, which I think is important, especially if it's a left main intervention. Naveen, and then maybe perhaps Ethan, you can just comment on that before we go to COVID on these left main STEMI patients. Naveen?
Yeah, I thought Tim's talk was terrific. It really hit on, the acuity of these patients, how sick they are when they come in. And there's no question that assessing these patients globally beyond just their coronary, I think is going to be critically important. These patients have low EF, as Tim indicated. They are highly susceptible to cardiogenic shock. We can prevent that downward spiral by what we do in the cath lab up front, including reperfusion and revascularization, as well as hemodynamic support. So yeah, I thought it was a terrific talk.
Ethan, what do you think about imaging? Do you image during a STEMI? Do you ever even think about it when the procedure becomes complex?
I mean, I think that would be a scenario where I'd image after the fact. So, I think the priorities are to stabilize the patient, impella as necessary, do the stent, and then typically in a left main setting, I would use the IVUS just to make sure everything looks good on the back end. If you have the luxury of time, I generally prefer to use imaging up front just to get the sizing perfect, but that's the case where I just can't wait.
Santiago, you gave a gorgeous talk on STEMI and COVID, huge for us in New York. It was a massive epicenter here We saw the data that Shripal and Benita published in the New England Journal with the very few patients, but important evidence. I can tell you that for us, it was never about thrombolytic therapy. I think we were always looking to bring these patients to the cath lab and so our algorithm did have early evaluation, especially use of echo, risk stratification, and quickly bringing them to the cath lab, very similar to, I think, what NYU was doing. Maybe you can tell us about how that was impacted in your region, and what did you do actually in your environment?
Yeah, we clearly had conversations about it. We certainly changed the triage of these patients. Instead of bringing them to the cath lab directly, send them to the emergency department where they could be assessed for COVID first. But yes, we made a commitment similar to what you're describing, to bring all these patients to the cath lab, because we felt that that was the right thing to do. In particular, many of these patients present with abnormal chest X-rays and CTs. I don't think thrombolytics will be helpful in those situations, and it can be harmful indeed. So I think the standard of care, I think, in the United States hasn't really changed. We prepare for the surge of patients that never materialize. I think the real important issue is how COVID is affecting the care of non-COVID patients. Even today, it's clear that this pandemic is not going away anytime soon, and we haven't yet seen the complete regression to the mean in terms of STEMI patients in many parts of the country. We have a follow-up observation on that, and we're still down by about 20+%. So I think the message that we send to the community, if you have shortness of breath, stay home for 2 weeks, self-quarantine, that needs to be recalibrated, certainly. And I think we have to do a better job at communicating with patients.
Yeah, and I think
one of the problems is that we, and I want to hear from Sripal a little bit, because, I think we took a lot of these patients to the cath lab thinking that we're going to do something that's intervenable that will rapidly turn the patient around. I think the study did show that a lot of these patients didn't have intervenable lesions, and that maybe they were more at the end stage of their COVID disease, and it may have actually pulled patients away from, their primary problem. What do you think about that? Is that how you took that?
Yeah, I think that's a great question. So I think we did see a spectrum, and if you look at the high mortality, most of them were dying from their COVID. It wasn't the STEMI which was actually killing them; it was the COVID. And just quickly going back to lytics, and as Roxana was pointing out, I think all of us on this forum agree. If lytics did not work before, it shouldn't work in the COVID era. And what we saw was, given that the presentation spectrum is wide, we have patients with angiographically normal disease, we have typical STEMI. The couple of patients who were licensed and shipped over to us, none of them had successful lysis of their clots. So they had to eventually go to the cath lab again. There was just delays. And I think part of the issue is, in terms of using lytics, is there is a delay in presentation, delay in care for these patients. So, and you can imagine, if it is delays, lytics is not going to be the best treatment strategy. And so that's one of the reasons we were still primary PCI. And one of the things that we saw in the COVID era is the use of POCUS. Even a POCUS done by the ER would be very helpful in such settings to figure out if there is wall motion abnormality.
Yeah, I'd like to hear from Atul. I know, and in our, we all have to get ready for our labs, and we've actually turned one lab for COVID positive patients. Everyone gets tested, and we're now seeing people who have COVID, who have mildly symptomatic but have STEMIs. And I heard from Dominic Angelillo, we talk all the time, and he said he was on call last week, and half of the patients were COVID positive. They weren't in for COVID. They had COVID positivity, but they were presenting with a STEMI. So I think we have to get used to this new normal. And Matul, what are you guys doing in your institution, and what do you think we should be doing?
Yeah, thank you, Roxana. I think we have a couple of people on this panel that are big proponents of protocols and algorithms. And what's unfortunate about everything that's going on right now is that because of the variability in and availability of rapid testing, it's very difficult to develop a protocol to manage these patients, right? We're fortunate at UC San Diego, where we have a rapid 15-minute turnaround test, and you can argue about the sensitivity and specificity of that test, but we have that, and it certainly makes us feel better because we have a result by the time the patient is being wheeled up to the cath lab. So I think it's a frustrating situation because of the variability and the availability of testing. But we have, as you probably know, we've always been doing primary PCI for these patients. We haven't been lysing them primarily if they show up at our institution. However, we are a referral center and do receive patients that have been lysed at other centers. So it's a bit of a mixed bag.
Wonderful.
Roxana, can I make a couple quick points?
Yeah, we need to close, so go ahead and make your last thing, Mr. President to be of Sky. I'll give you that, and then Manos will close.
So, and three really important points. So number one, our thinking's evolved a lot, and this is coming from spending a lot of time with people across the United States and to inform the Sky ACC guidelines on this. I think there's key things. PCI is clearly the answer. In these patients, you can go to the cath lab, you can do it safely. We know now that spread in the cath lab, if you have proper PPE, is almost zero. So go to the cath lab and do best care just like you should. Number two, everybody that's listening, join NACME, because we've made it very simple, and we need more data so that we can actually inform the best care. What are the percentages of no culprit? What are the percentages of mortality? And we need to know that. So join. Number two, join. And number three, we need to tell patients it's safe to go to the cath lab, because we had a crisis in this country because we scared people to death, literally. And the Sky has a campaign called Second Still Count that's been wildly successful. And that's available for your local market. And so a lot of places around the country that have done good PR have actually increased their STEMI volumes back to where they should be. And we've made it safe to patients to come back to the hospital.
But again, thank you all. It was a tremendous session. Hopefully we'll see you next year in Austin, and enjoy the rest of the meeting. Thank you.
Yeah, I'd rather be with you guys.
We're going to be together. We will be together very, very soon. Thank you for having us.
Bye, everybody.
CVI. CVI.
Nice. Stay safe.